just invite our first speaker for the session, Professor Gillian Lamoury from Radiation Oncology Department, Royal North Shore Hospital, Australia. And she'll be talking about the gut microbiome and vasomotor symptoms in women with estrogen receptor positive breast cancer. Ma'am, I welcome you on the stage.
And thank you to the organizing committee also for the opportunity to speak and present my data. I was first invited to speak at this forum in Bangalore 2 years ago. My background is as a clinician. I have a research interest particularly in metabolomics, lipidomics, and this is my foray into gut microbiota. We as clinicians need to, I've realized more and more as I've evolved in clinical practice, need to practice not within silos but with our translational and allied colleagues. So this is an attempt to integrate gut microbiota into my clinical work. I predominantly treat breast cancer. So I would like to first look at some background history and where the current research and data are in relation to gut microbiome and women's health. And this is an emerging area of research interest and publications. And this is because, in fact, we know that there is a strong correlation between gut microbiome and immunity, of course. COVID taught us that. But in particular in women's health, there's a relationship between endometriosis, certainly within other cancers, not just breast cancer, ovarian and cervical cancer included, and also other inflammatory conditions such as endometritis. Is the gut microbiome itself related to menopausal symptoms in breast cancer patients and in fact normal patients, normal women rather, non-patients, and is their experience of menopausal symptoms and vasomotor symptoms affected adversely because of a disruption in the gut microbiome? We know that menopause itself, that physiological process which all women undergo, is associated with a disruption in the gut microbiome and estrobolome, and this has been published. And here in particular, I highlight a Latin American series talking to this. But what about with breast cancer itself? Are there any data yet? And in fact, in the last 4 years, there's been an explosion of clinical evidence. I've just listed 6 or 7 of these here for your reference. We know that the fecal microbiota composition varies between healthy controls and breast cancer women. And there's a comparative case control study that I'll describe briefly. We also know that there is a difference in the gut microbiota in menopausal status, pre versus postmenopausal women with breast cancer. We know that their experience and tolerance of therapies such as CDK4/6 inhibitors for the clinicians in the room is also impacted by their gut microbiome. And we know that there's a variation, which is non-surprising, that exists with various ethnic groups. And in addition to CDK4/6 inhibitors, the experience of women who are taking aromatase inhibitors, and that's the majority of women with hormone-sensitive breast cancer, also has a relationship and a correlation with their gut microbiome. And this, there is an observational cohort study that I'll briefly describe. So the first study comparing normal healthy controls and women with breast cancer, this is a comparative case control study, does show a statistically significant difference between the presence of gut microbiota, and in particular, the overabundance of the Clostridiales, or the Clostridium, particular the clusters 4 and 14A, seen in breast cancer compared to normal controls, as is referenced in these 2 slides. And then if we look at the subtypes of breast cancer, this is the molecular subtyping of breast cancer into hormone-sensitive, HER2-positive, and triple-negative groups. There is also a distinct difference in the bacterial taxa seen in these 4 molecular subgroups of breast cancer, with a significant differential prevalence between the subtypes as seen in this bar plot. You can see that the triple negative, the bottom cohort, there is an abundance of certain microbiota that are not seen in the non-triple negative cohort or in the luminal B cohort. And then the microbiome in relation to postmenopausal women with luminal B, these are hormone sensitive breast cancers who are treated with aromatase inhibitors. This is an Italian observational cohort study talking to the fact that whilst there is no statistically significant difference seen in the average abundance of the various phyla, class, and order between cases and controls, there was, in terms of the family, the Veillonella group of microbiota, there was a maximum abundance seen in cases versus controls, which was statistically significant in this particular observational cohort study. So my interest and the interest of our group studying this, and we are a multinational collaboration of researchers looking at this particular aspect, is in terms of what is the experience of vasomotor flushes or postmenopausal symptoms in women who have hormone-sensitive breast cancer in relation to their gut microbiota. So some background into the cohort of women that are included in my study. We know that current guidelines for women with breast cancer that is hormone sensitive, we call this a luminal A and B subtype, treated with oral endocrine therapy, either tamoxifen or more recently the aromatase inhibitors, is a minimum of 5 to 10 years to maximize their disease-free and local regional survival. But we do know that a proportion of these women either discontinue transiently or indefinitely their endocrine therapy because of the experience of adverse effects. So what we would like to study is a safe and, whilst this is a safe and effective therapy for women, is what would keep them on it with less experience of these adverse effects to maintain their long-term disease-free control. What are the particular side effects that these women experience which causes such a quality of life impact? Well, more than 2/3 of them after breast cancer treatment will have significant hot flushes and night sweats, which may impact upon a range of parameters, including sleep, cognitive function, mood, arthropathies, arthralgias, joint pain and stiffness, and overall quality of life. We aren't exactly sure what causes these vasomotor hot flushes, but we think there's a link between a depletion of their estrogen profile and the core body temperature. And a simplistic explanation from a physiological perspective is that when it's too warm, the body goes into overdrive trying to cool off. It causes vasodilation, which brings the blood to the surface of the skin to dispel this heat, causing it the experience of this hot flush. The current management strategies that we advise our patients to improve this particular adverse impact is to stay cool or to try things such as antidepressants, SSRIs in particular, acupuncture, which has some compelling evidence for its use, having a good lifestyle in terms of exercise and diet, and to avoid triggers which are not necessarily strongly correlated, but there is some qualitative evidence to suggest reduction in alcohol, smoking, and caffeine may reduce the experience of these symptoms, but this is not necessarily clear-cut. So our research project is looking at the effects of gut microbiome on the experience of vasomotor symptoms in women with hormone-sensitive breast cancer. So our primary aim is to actually identify, if we can, the composition of gut microbacteria between breast cancer survivors with hot flushes and those who are not experiencing these symptoms, but all of them are taking aromatase inhibitors, anti-estrogen therapy. A secondary aim of this study is to identify the relationship of this composition of gut microbiome with sleep quality, mood, in particular anxiety, depression, arthropathies and arthralgias, and related to estrogen sensitivity and the expression of beta-glucuronidase activity on these women. So this particular review article published just less than a year ago shows us what the impact of beta-glucuronidase in the gut in the gut, how it impacts development of breast cancer, but also the experience of women with vasomotor flushes. So we know that estrogens are conjugated in the liver, they get deconjugated in the intestinal tract, and then free estrogens are impacted upon by the gut microflora in being bioavailable to end organs such as breast. And there are many bacterial producers of this beta-glucuronidase that I have listed, and in particular the Clostridium group, which I showed you in my initial slides, which there is an overabundance of in breast cancer compared to normal controls. So whilst the gut microbiome in our primary hypothesis is thought to be a predictor of this adverse effect, flushes, and therefore mood, sleep, and depression, in women undertaking aromatase inhibitor therapy because they have breast cancer, we have planned to recruit 60 women and as case controls their carers, and there will be 20 of those. We collect baseline quality of life data and biospecimens both from stool and from blood, and analyze using PROMs and quality of life data, both the gut microbiome and blood specimens. And we do that at 3 time points at baseline before they have commenced their anti-estrogen therapy, at 4 to 5 weeks following commencement of the aromatase inhibitors, and then just after 3 months as well. Our current study is still in its infancy. It opened with the support of 3 funding grants in October. We have thus recruited 8, 2 dropped out because of a non-receipt of the specimens within the specified 36 hours, so we have 6. We have also recruited 3 carers or controls, and we hope to be able to complete our recruitment in June of next year. We are a cross-collaborative team of mainly breast cancer specialists, but they include breast cancer surgeons, radiation oncologists such as myself, medical oncologists, and thanks in particular to Professor Byung-Sang Oh, referenced at the bottom of the slide, who is both a practitioner of traditional and complementary therapies from South Korea, along with the 3 funding grants that we have been successful in securing to be able to run this study. I would like to thank my co-collaborators, and we are from across the world, from MD Anderson Cancer Center, Dana-Farber, and Harvard Institute, and I'm representing the University of Sydney and Royal North Shore Hospital, where these patients are being recruited from. And with that, I thank you for your attention.